guys. So the topic of today's video is leg pain. Leg pain is something that can vary from simple cramps like pain to arterial occlusion. And leg pain is very important for AMC because we cannot find it somewhere else in this summarized manner. And AMC likes to test it under the headings of DVT and under the vascular occlusion ischemic pains. So, some serious disorders which we should not miss when we are dealing with leg pain can be under the, neoplasia. In neoplasia, there can be malignancy. If there is a history of primary tumor, there can be metastasis towards the bones, which can cause the leg pain. Osteogenic sarcoma, multiple myeloma. They usually affect the upper half of the femur. We can also have infections like osteomyelitis and septic arthritis, and these are the disorders that can be lethal. So we have to pick these disorders early. Vascular disorders are very important when we are dealing with leg pains. They comprise of thromboembolic events, DVT, thrombophlebitis, and these can be chronic or acute. They can be presented as chronic or acute. The chronic vascular problems, the sign of chronic vascular problems can be intermittent claudication. So, the intermittent claudication can be classified as neurogenic versus vascular claudication. The neurogenic claudication is when there is a spinal canal stenosis and the patient has a long history of backache, while vascular claudication is due to aortoiliac arterial occlusive disease. The pain of the neurogenic claudication is usually experienced by the patient when he is walking or exercising. And if the patient is walking upward or downhill, and the time of onset of pain can vary. The distance varies when the patient starts to get pain, and the pain usually travels from proximal to the distal body. Like the pain would be started in the buttocks and back, and then it would radiate towards legs. While the pain of vascular origin would be traveling from distal to the proximal side, and it is especially in the calves, and the distances would be set in case of vascular claudication, while the in neurogenic claudication, the distance would vary when the patient would start to get the pain. So the in vascular claudication, the pain is usually felt by the patient when he is going uphill, and there is a set distance each time. So the patient of neurogenic claudication would be relieved by lying down or flexing in supine position, and it can take up to 20 to 30 minutes. While in vascular claudication, the patient would get fast relief, and he can get instant relief while standing still. There can be some associated symptoms like in neurogenic claudication, the patient can experience bowel or bladder symptoms, while in vascular claudication, the patient can has impotence and paresthesia or weakness can also be there, but rarely. So, coming towards the individual causes of leg pain, so the number one and most common cause of leg pain are the spinal causes. So, spinal causes can be nerve root pain like radicular pain, referred pain, or spinal canal stenosis. We have to memorize certain nerve roots where they are their distribution and what are the pain distribution site when these nerve roots are affected. For example, we have L3. The pain distribution would be front and inner of the thigh, and the sensory loss would be at anterior thigh. Extension of the knee would be affected if the L3 is affected, and the knee jerk, and the reflex would be the knee jerk. So in case of L4, the pain distribution would be at anterior thigh and from anterior thigh to the front of the knee, and the sensory loss would be lower outer thigh and inner great toe. An inversion of foot would be weakened if the root of L4 is affected and knee jerk is affected. L5, the pain distribution would be lateral leg and dorsum of the foot. Sensory loss would be dorsum of the foot, great toe, second, third, and fourth toe. And the motor function that would be lost is dorsiflexion of the great toe. Patient will not be able to dorsiflex his great toe and ankle. S1 is very important, and the pain distribution would be from buttock to the back of the thigh and leg, and the sensory loss would be lateral ankle and foot. The patient would not be able to plantar flex. Patient would not be able to plantar flex of ankles and toes, and there would be eversion of foot. Reflex that would be affected is ankle jerk. Now coming towards sciatica. Sciatica is actually the pain in the distribution of its branches like L4, L5, S1, S2, and S3, and it is due to the nerve pressure or irritation. And the classic symptom that is back pain can be absent, and peripheral signs may only be present, like the patient has only leg pain. Sciatica can present like this. Um, Usually, the pain and the management of sciatica is conservative and symptomatic treatment. But if there are neurological signs and symptoms, it is progressing towards neurological signs and symptoms, then we are going to consider the surgery. Now coming towards lumbar spinal canal stenosis, spinal canal stenosis, the spinal cord canal of the spinal cord can get stenosed due to number of reasons, and the classical symptoms would be neurogenic claudication. Nerve entrapment syndromes. Nerve entrapment syndromes are when the nerve, which is passing through a narrow rigid compartment, um, the movement and stretching of the nerve comes under the pressure due to the rigid compartment due to any reason. Features would be pain at rest, which is worse at night, and the distribution of the pain would be clearly demarcated area. Under the nerve entrapment syndromes, there are a number of nerve associated syndromes like neuralgia peristatica. It affects the lateral. In this disorder, the lateral femoral cutaneous nerve is trapped under the inguinal ligament, and it is usually associated with pregnancy, obesity, ascites, or local trauma like belts and corsets. And pain is usually felt at the lateral thigh. Now the peroneal nerve entrapment. Peroneal nerve, when the peroneal nerve entraps, the pain would be felt at the lateral shin, and there would be weakness of eversion and dorsiflexion of the foot. If the obturator nerve gets entrapped, the pain would be in inner thigh, and if the posterior tibial nerve is entrapped, like in tarsal tunnel syndrome, there would be pain in sole of the foot. Coming towards the vascular causes, which is the most important thing for AMC in leg pain. So, vascular causes, the risk factors for vascular causes are smoking, diabetes, hypertension, hypercholesterolemia, family history, and atrial fibrillation. The aggravating factors can be beta blockers and anemia. So if the patient is experiencing six P's, six P's are like pain, pallor, pulselessness, paresthesia, paralysis, perishing cold. These are the six P's you have to keep in mind when you are dealing with acute limb ischemia. And if the patient has these, we can suspect acute lower limb ischemia, and this can be due to a number of reasons. For example, if the patient is coming with trauma, or the patient has acute obstruction of any artery, he can present with acute lower limb ischemia. So, acute lower limb ischemia can be due to acute embolism or thrombosis. The symptoms of acute embolism and thrombosis are same, although the symptoms of thrombosis, if the patient has thrombosis, there would be preceding symptoms of chronic disease, like the patient would be having a history of claudication. So the commonest site for the occlusion is common femoral artery. A very important point that if the foot becomes dusky purple and it fails to blanch on pressure, that means the necrosis, irreversible necrosis, has occurred, and it is usually after 6 hours, and it gets irreversible, the treatment gets irreversible, and the amputation would follow. But if the patient is treated within 4 hours, the condition would be reversible. We can test with Berger test. What is the positive Berger test? It is pillar on the elevation of the limb and rubar on dependency, and it indicates chronic ischemia. It is the indication of actually chronic ischemia. Coming towards the management of acute lower ischemia would be done through guidelines. Now, coming towards the chronic lower limb ischemia. So, chronic lower limb ischemia is, we have done it before, that it is presented with intermittent claudication or rest pain in the foot or overt tissue loss. These can be the presentations of chronic lower limb ischemia. So, overt tissue loss can be presented in the form of ulcers or gangrene, and the intermittent claudication would be experienced by the patient when he is exercising, and it would be released by rest. So there are two things, that is intermittent claudication versus ischemic rest pain. Intermittent claudication, the pain of intermittent claudication would be like tightness, while the pain of ischemic rest pain, it is the constant pain. Ischemic rest pain is at night and while in resting condition, while the intermittent claudication is felt during the daytime and during walking. Muscle is affected in intermittent claudication, and there would be calf more than affected in thigh than more than buttock, while the ischemic rest pain is usually for foot, toes, and heels. If the patient rests, the intermittent claudication can be relieved, while in ischemic rest pain, if the patient hangs its hanging foot out of the bed, can relieve the pain of ischemic rest pain. The intermittent claudication can be aggravated when the patient is having beta blockers or anemia. And ischemic rest pain is associated with night cramping and swelling of the feet. When the patient gets the vascular obstruction, the obstruction can be proximal. If the aortoiliac arteries are involved, and the pain would be felt in buttock, thigh, and calf. There would be persistent fatigue over the whole lower limb, and impotence is possible when there is proximal obstruction. While if the obstruction is at the level of thigh, there would be the artery would be affected, that is superficial femoral artery, and it is associated with the calf pain. Now, coming towards the superficial thrombophlebitis, and it is usually in the superficial varicose vein. And on examination, there would be tender red and subcutaneous cord felt in the leg. And it can be the complication of intravenous infusions, like if complication of IV, the patient would be treated with NSAID, and if the thrombophlebitis is spontaneous, he would be treated with low molecular weight heparin. And we would be managing the patient symptomatically, and we will give him symptomatic relief unless the thrombophlebitis and the pain gets above the level of the knee. Then we are going to refer the patient. So when we are going to refer the patient to the vascular surgeon, if there is unstable or severe unstable claudication, that is a new onset and that is worsening, or if there is severe claudication that is hindering the normal lifestyle of the patient, there is rest pain, tissue loss at the feet, like the patient is having ulcers and gangrene, and tissue losses between the toes. There is reconstructive surgery indicated, like endarterectomy, and another referral points would be if the patient has popliteal aneurysm, thrombophlebitis above the knee. There is evidence of the DVT, and the doctor, the GP is suspecting the gas gangrene. There is worsening of the hip pain, and sudden onset of 6 Ps like pain, pillar, pulselessness, paresthesia, and paralysis. There is evidence of disease in the bone, like there is cancer or malignancy, Page's disease, or infection. So that's it for the leg pain. Thank you. You can tell me in the comments that which important topics you want me to cover from John Murtagh, and I will make the video. So make sure to subscribe the channel because I will be posting many important videos regarding AMC preparation, other playlists and other series I would be making. Our guidelines. I know that guidelines change with the time, and after some years the guidelines they get repeated, but I will give you the overview that how can we learn from guidelines so that it becomes easier, and you do not have to do everything in on mention on the guidelines. Thank you.